When you attend RSNA 2023, our industry influencers and radiology trailblazers are set to help you embrace what's next in medical imaging. Imagine what new medical imaging practices and technology can teach about collaboration and innovation. We have everything you need, all in one place, as we help you explore how to lead through change. Join us November 26th through the 30th for the biggest week in radiology, in person, virtually, or both. Early bird pricing is available through October 4th. Register now for RSNA 2023 at rsna.org/register.
Hi, everyone. This is Dr. Celina Nahyun Jo, one of the trainee editorial board members in Radiology, Imaging Cancer. I'm a radiology resident in University of Texas Medical Branch at Galveston. We are launching a new podcast series where we summarize interesting articles into a bite size. This podcast aims to provide background knowledge for everyone to understand and enjoy oncologic imaging research on the go. This is bite-sized research for Radiology Imaging Cancer, July 2023 issue. Today's article is from Linkrod Institute of Radiology in the United States. The first author is Dr. Marilyn Siegel, and the senior author is Dr. Barry Siegel. The title of the article is Discrepant Assessment of Progressive Disease in Clinical Trials Between Routine Clinical Reads and Formal RECIST 1.1 Interpretations. A little background on RECIST Criteria 1.1. In the last episode, I introduced you to modified RECIST and EASL criteria that stands for European Association for the Study of the Liver. These are developed to assess the response to local regional treatment targeting hyper-enhancing tumors, such as TACE or HCC. These criteria determine the visualization of enhancement after contrast injection, where residual intratumoral enhancement is considered as a viable tumor. RECIST 1.1 criterion is widely used to measure solid tumors' treatment response. This was established in 2009 as an improved version of initial RECIST criteria developed based on WHO response guideline first published in 1981. This tumor size reporting system standardizes and provides a structured, reproducible analysis for the therapy response. The baseline study should be assessed for eligibility to apply RECIST criteria. CT is a preferred modality, but MRI or even a chest X-ray can be used in some instances. But ultrasound is not used for RECIST due to operator dependency. Then the target lesions are selected. This is a maximum up to 2 lesions per organ and a maximum of 5 lesions in total per study. Lymph nodes can be chosen as a target lesion only if it exceeds 15 mm in short axis diameter. If the patient has non-measurable but cancer-related findings, such as leptomeningeal disease, ascites, pleural effusions, or skin involvement, these can be assigned as non-target lesion, and instead of measurements, simply presence versus absence is reported upon follow-up. Things to remember when measuring target lesions include when measuring hyperenhancing tumors, the hyperenhancing rim should be included in the measurement. In non-spherical tumors, such as mesothelioma, it is difficult to measure the long axis as it grows along the chest wall. The tumor thickness is perpendicular to the chest wall, measured from the 2 different levels, is reported in these. Bone metastases are considered non-measurable lesions. However, if there is a soft tissue component to a lytic lesion, these can be considered measurable target lesions. In mobile tumors, such as gastric cancer, it is understandable that the stomach may move on subsequent follow-up, and it may be difficult to accurately measure the tumor in the same dimension. The nearest largest lymph node can be considered as a target lesion in this case. When we measure the target lesions, the sum of the longest diameters of the 5 target lesions is reported, and this is often called by the abbreviation SLD. In summary, the baseline report contains modality and parameters, description, location, in the size of the target lesions, description of non-target lesions, and any other incidental findings, with a conclusion and summary of the above. Follow-up imaging should be performed with the same modality and parameters, such as contrast timing or slice thickness. The target lesion identified in the initial study should not be changed, although the orientation of the longest diameter can be different from the initial study. The previous measurements should not be changed. If the patient received RF ablation or cryoablation, the tumor should not be measured since the ablation coverage is larger than the tumor size. During the follow-up, if the long diameter of the target lesion drops below 10 mm, the lesion still counts up to the sum of the diameters, SLD, and a default value of 5 mm is assigned. When cavitation occurs during the treatment, the lesion should still be measured in the longest diameter. In lymph nodes, when the short axis diameter drops below the normal size of 10 mm, the measurement is still counted for the calculation of the SLD. This means SLD does not have to be 0 to obtain a complete response. Any new lesion or reappearance of disappeared lesions means progression of disease. The rationale is that the most lesions do not disappear, but are under the detection level of the imaging modality. Finally, when you conclude the report, there are 4 response categories: progressive disease, stable disease, partial response, and complete response. Progressive disease indicates more than 20% increase in sum of length diameters, the SLD. In addition, the sum must also demonstrate an absolute increase of at least 5 mm. Any new lesions is also considered a progressive disease. Partial response is at least 30% decrease in the sum of the longest diameters of the target lesions compared to the baseline. Stable disease is between partial response and progressive disease, which means neither a sufficient decrease nor an increase. The complete response is a disappearance of all target and non-target lesions. Any pathological lymph nodes have a reduction of short axis to less than 10 mm. Other than RECIST criteria, multiple other criteria are used in different tumor types, like the modified RECIST from the last episode. CHOI criteria are used in GIST treated with imatinib, iRECIST for immunotherapy as the tumors tend to have pseudoprogression after immunotherapy, Lugano classification for malignant lymphoma, or modified Ann Arbor staging system for Hodgkin and non-Hodgkin lymphoma. All right, so let's get back to our study. Why did the authors do the study? RECIST and other similar response criteria are generally not widely implemented in formulating routine clinical interpretation. The tumor lesions are often described subjectively. At the author's institution, most patients on clinical trials receive standardized measurement by the core laboratory. The authors focused on the progression of disease interpretations since these are the most likely disrupt patient care, often including discontinuation or change of therapy. Methods. Patients in solid tumor clinical trials undergoing imaging response assessments based on RECIST 1.1 from January to July 2021 were included. The routine clinical interpretations were compared to the core laboratory interpretations done by specially trained radiologists who use software that tracks target lesion measurements, changes in non-target lesions, and the appearance of the new lesions. This included imaging of the chest/abdomen, or chest-abdomen-pelvis CT scans, or abdomen-pelvis MRI scans. The software tracks the target and non-target lesions, new lesions identified over serial studies, and measurements. The software then calculates the sum of the diameters of the target lesions and calculates a target lesion response based on the change. The imaging response assessment core radiologist assesses the progression of non-target lesions and search for new lesions. The software determines the overall response assessment per RECIST 1.1 criteria based on all above. The determination of progression of disease in the routine clinical report was based on the impression of each report with specific keywords that a referring oncologist would likely interpret as indicative of progression disease. This included such phrases as following: progression, progression of disease, findings most consistent with, or suggesting, or suspicious of progression of disease, worsening of disease, increased size of previously noted lesions, and new metastatic lesions. When the findings were characterized in the impression as indeterminate or suspicious for progression of disease, but with follow up or clinical correlation recommended for confirmation, this was not considered as progression of disease. Results: 1,053 patients underwent 1,822 follow-up CT and or MRI examinations between 1st of January and 31st of July in 2021. There was 327 progression of disease assessments on either the clinical report or core laboratory interpretations that form the basis of the analysis. The clinical report and core lab agreed on progression of disease status on 65% of the patients. In the rest, about 32% of the clinical report diagnosed progression of disease, which core lab diagnosed stable disease. In about 3%, the core lab diagnosed progression of disease when the clinical report diagnosed stable disease. This discordance between clinical report and core lab interpretations of the progression of disease was statistically highly significant. They looked into the reasons for overdiagnosis of the progression of disease on clinical reports by comparison with the corresponding core lab interpretations. The discrepancies were as following: clinical report overdiagnosing progression of disease based on differences in target lesion measurement occurred in 61 over 105 cases, which was 58%. In 49 patients, progression of disease was based on an insufficient increase in target lesion size, which is supposed to be more than 20% change in sum of diameter, as is required in RECIST 1.1 to declare progression of disease. In 12 patients, progression of disease classification was based on the evaluation of an insufficient number of lesions. For example, progression was based on only one lesion, even though multiple other lesions were stable in size or had regressed. Clinical report overdiagnosing progression of disease based on differences in non target lesions occurred 32 out of 105 patients, which was 31%. The discrepancies related to clinical report assigning non target progression of disease based on insufficient increase in size or a number of soft tissue lesions, increase in the sclerotic bone lesions, and increase in volume of ascites or pleuroeffusion. These increases were considered to be inadequate evidence of progression because they did not meet the criterion of unequivocal substantial worsening of the overall tumor burden. Clinical report overdiagnosing progression of disease based on new lesions occurred in 12 out of 105 patients. The causes, including declaring the following as new lesion, was normal sized lymph node that was less than 10 millimeter in short axis, small volume ascites, sclerotic bone lesions, and lesions present in prior studies. Conclusion: the study showed that the disagreement between clinical read and core laboratory reads were in 35% of the patients, with clinical reads overcalling progression of disease relative to RECIST 1.1 in most of the cases. The overdiagnosis of the disease based on target lesion assessment is often linked to inadequate increase in sum of diameter, which was mostly less than 20%, or assessing a single target lesion despite the presence of multiple measurable lesions in other organs. To accurately represent tumor burden, RECIST 1.1 mandates assessment of up to 5 target lesions. Perspectives. Differences in evaluating disease progression between clinical reports and current standard of care can impact patient care and trial results. This data supports the use of imaging core lab can minimize variability in response assessment errors. The baseline study and measurement should be readily available on electronic medical records to improve these discrepancies. Radiologists and radiology residents need formal training in applying RECIST and other response assessment criteria. If you would like to review RECIST 1.1 criteria, you may return to the introduction of this podcast. With the advancement in artificial intelligence applications, tedious quantitative assessments such as lesion measurements, size tracking, and structured reporting can be automated and readily available for radiologist approval. Thank you for tuning in. This was Bite Size Research for Radiology Imaging Cancer, July 2023 issue, and I am Celina Nahyun Jo. Please check out our latest issue of Radiology Imaging Cancer on our website for more interesting articles.